this 43rd Lahore Ophthalmo, and it is 47th National Conference, and it is a great matter of pride for us all that we are also collaborating with Pakistan Ophthalmology Association Annual Symposium, and great effort with the President present here, sir. Thank you very much. So let's start with the recitation from Holy Quran. Ibrar.
Bismillahirrahmanirrahim. إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفره إنه كان توابا صدق الله العظيم.
Oculoplastic Association POA Symposium 1, which is Video Symposium. Our first talk will be by Dr. Muhammad Sharjeel, which is about the large orbital foreign body removal.
A sort of competition as well. So I would request Professor Ibrar. So kindly comment on the quality. वो एक पेपर, दो पेपर दे दें बेटा, पेन और पेपर दे दें. So we would rate these presentations, and tomorrow's dinner, they will receive prizes. Brigadier Amir Yaqubi is also here. Sir, हम आपको judge declare करें.
Now we can start. An interesting case of a large orbital foreign body, and the background is that he's a madrasa student, and they had a fight, and one student put this pen tip in the eye. Now when I examined the patient, as you can see here, I thought it's just a tip, but when I started to explore, we will see what it is. So the one thing I should say that, yes, that's an excellent question. I was talking about it, that whenever, even if a foreign body seems smaller, we should definitely opt for imaging, because I thought it's a small pen tip, so why should I do imaging? But after removal, I thought if I would have done an imaging, I would have presented as a case report. But now, as I haven't done it, so it's an incomplete case. So imaging is very important in such cases. Thank you.
So the forceps, because you were using the forceps, were very fine. I think that was the one available in the OPD. But if it was me, I would use an artery forceps or something bigger, so that it doesn't cut through. Challenge.
So is Dr. Memon ready, Doctor, with his lateral tarsal strip? The video is uploaded? No? Okay, then how about Sadia? Okay, so Sadia will talk about minimal invasive eyelid lift, or what she calls MINEL.
Assalamualaikum. I am Dr. Sadia Imtiaz from your hospital. Our video presentation is about minimally invasive eyelid lift, which is also known as MINEL. I have no financial disclosure to make. Upper eyelid hooding is a common problem, where the upper eyelid crease is hidden by the lid fold. As you can see in this picture, if you talk about its causes, it's because of some genetic factors. It can be because of ethnicity difference, that the East Asian population has more of this upper eyelid hooding. Aging can also contribute towards this condition because of skin laxity and the eyebrow ptosis. Among environmental factors, it can be the sun exposure or smoking. Conventionally, it's being treated by upper eyelid blepharoplasty that requires the removal of skin, muscle and the fat. While moving towards new trends, is it possible to lift eyelid without skin removal? And yes, here comes our technique, which is minimally invasive eyelid lift, also called as MINEL. In this technique, the basic principle is that the upper skin is tucked in and a new crease is shifted at a higher level where the patient wants it. pre-op markings are made in the sitting position, one at the mid-pupillary area and the other at lateral canthus area. If we talk about its procedure, after local anesthesia installation, 2 incisions 3 to 4 mm long are made at the level of pre-op markings. Dissection is carried out, orbicularis muscle is separated, and preseptal tissue is removed to reach the orbital septum, which is then opened. Preaponeurotic fat pad is removed with the cautery, and beneath this orbital preaponeurotic fat pad there is this white shiny levator aponeurosis. Non-absorbable Parolin 60 suture is used to tie this levator muscle with the orbicularis muscle, which will shift the crease to a higher level. The same procedure is repeated at the lateral canthus marking, and here you can see the lateral horn of the levator muscle is tied with the orbicularis muscle. If we talk about its result, upper eyelid hooding is beautifully corrected by this technique. And after results, there is the lid crease is shifted at a higher level and there is no scarring. If we talk about its advantages, it's a simple procedure with a small wound that leads to a scarless surgery afterwards with a natural skin increase at a higher level. This is a reproducible and repeatable procedure with skin preservation, thus leading to less chances of lack of thymos. But definitely it can have certain limitations. There can be difficulty in visualization because of small incision. Iatrogenic ptosis can occur because of trauma to the levator muscle. And if we talk about its severity, then the severe hooding cannot be corrected by any nail. In conclusion, minimally invasive eyelid lift is a novel technique to lift upper eyelid without skin or muscle removal, and subsequently it can be considered as a good alternative to invasive upper eyelid blepharoplasty. Thank you for your attention. If you have any questions, feel free to contact.
But it's a fantastic procedure. In the interest of time, maybe we'll save some questions for later, maybe so we can keep on going. Thank you so much. So we'll maybe have Dr. Muhammad Idris come by and talk about anterolamellar repositioning for managing upper eyelid entropion. Or is there a video? Is Dr. Idris here? Okay. Shall we move on to the next one then? Dr. Faizan Tahir, who's talking about orbital decompression, endoscopic transnasal. Dr. Faizan, go ahead.
Dr. Faizan Tahir. My video is about, as it says, endoscopic medial orbital wall decompression for thyroid eye disease. The video has a voiceover, so I'll just play it and we'll enjoy this together. The patient is a young lady having a burnt out thyroid-related eye disease. Her main concerns were cosmesis due to exophthalmos and diplopia because of muscle restriction. She already has had a lateral orbital decompression with partial improvement, and the scar is an evidence of that. And we planned her for an endoscopic medial orbital wall decompression. Before showing you the surgery, let me explain a bit about the anatomy of the lateral wall of the nose. This is the middle turbinate that serves as a landmark to the osteomeatal complex. The infundibulum here is a key space related to the osteomeatal complex. The infundibulum is that space which is bordered medially by the uncinate process, laterally by the lamina papyracea, which is a thin bone that makes up the orbital cavity here, and posteriorly by the ethmoidal bulla. This space is hiatus semilunaris, which describes an area for drainage of maxillary, frontal and anterior ethmoidal sinuses. We need to expose this area by doing infundibulotomy in order to approach the maxillary ostium. The main thing here is to enlarge the maxillary ostium so that the prolapsed fat by medial orbital wall decompression does not block this opening, which, if happens, can lead to chronic maxillary sinusitis. Now, coming to the surgery, we start off by medialization of the middle turbinate and then packing the middle meatus with an adrenaline and lignocaine soaked gauze. So once the space becomes adequate, we identify the landmarks like hiatus semilunaris here, the bulla ethmoidalis posteriorly, and the uncinate process here. So now we need to do the infundibulotomy by incising the uncinate process. Once the infundibulotomy is done, we identify the opening to the maxillary sinus and then enlarge it with the help of a Foley's catheter by placing the catheter's tip inside and then inflating it. We divert our attention to the lamina papyracea. We chip off the thin bone to expose the periorbita here. Now the next step is to incise the periorbita and to prolapse the orbital fat. So once we incise the periorbita, we can see the orbital fat bulging out of this space. And now the next step is to gradually enlarge the incision bluntly with the help of a hook so that an adequate amount of fat gets prolapsed into the nasal cavity. The patient on the first post-op day has a significant improvement not only in cosmesis but also in her extraocular movements, and she reported improvement in her diplopia as well. This concludes our surgical video. Thank you for watching.
So next speaker is Dr. Sophia Iqbal. Her talk is about and surgical precision in dermolipoma excision.
This is a case of dermolipoma. Surgical excision of dermal lipoma is something which needs a lot of care because of the potential complications of strabismus and also damage to the palpebral part of the lacrimal gland. In this patient, we have given subconch injection of xalocaine with adrenaline, and incision is given medial to the lesion with a Westcott scissor. Dissection is done between the conjunctiva and the lesion. Here we have put a traction suture on the posterior part of the incision for a better view. The most important thing and the take-home message is that we have to be very careful while taking it out, especially in the superior part where there is the palpebral part of the lacrimal gland. Damage to this area can lead to a chronic dry eye, so we have to be very careful here and make sure we do not take out the complete lesion. You have to take about 80 to 90% and leave behind the rest for avoiding the damage to the lacrimal gland. The other important thing is that the conjunctiva should not be excised because it can lead to cicatricial strabismus. In the posterior side, when you are doing dissection, make sure it is between the tenon and the lesion. And posteriorly, when you go, don't go too close because there is a lateral rectus muscle and that can lead to motility disorders in the patient. The potential complication risk should be explained to the patient before the surgery. And you can also tell the patient that the bulk of the lesion will improve, but the color may remain the same because of leaving behind the residual lesion. So in this case, we are going step by step and very careful dissection is being done. Now this is done on the posterior side. Make sure the lateral rectus is saved. No damage should be done here. And the dissection is between the tenon and the lesion. The risk of cicatricial strabismus is another complication if we are not too careful with the conjunctiva. So now the lesion is taken out, about 85 to 90% of the lesion, not completely. Now conjunctiva has been closed with 6 Vicryl, and we are doing a interrupted sutures. This is the lesion, and these are the pre and post-op photograph. Now the patient, as you can see, has no motility disorder, and this is the result on the third post-op day. Thank you very much for watching the video.
A lot of this is you get the orbital fat that prolapses forward, but it's actually not a lipodermoid, which is a specific pathological diagnosis. Yeah. Okay. I find it's very difficult sometimes to separate the conjunctiva from the dermoid, and so you sacrifice conjunctiva, and then you're left with a big defect. How do you fix that defect?
In this case, it was easier to.
Yeah.
Otherwise, it is to.
The or amniotic membrane.
Yes. We proceed with amniotic membrane. Yes.
Yeah.
So you need to preserve as much of conjunctiva as possible, and sometimes you can do without a graft. Otherwise, if the defect is large,
Big.
you need to cover it with a graft. And the fat prolapse generally happens in older individuals,
Yeah.
not in younger patients.
But I think the key message here is don't go to posterior.
Yeah. You
Yeah.
have to resist that temptation.
It's like tip of the iceberg. You take the top off, leave the iceberg behind you.
Okay. So the next talk is by Dr. Adnan Abdul Majid. Do we have? Yes, please. His talk is about lacrimal tear repair.
Good morning, everyone. Today my talk is lacrimal, that is the clavicle tear repair. So there are the multiple ways of doing that clavicle tear repair, and some are stents, and because of the availability and the cost effectiveness, we usually do with the pigtail. So this is a video showing the clavicle repair by the pigtail. So as the first step, after the local anesthesia, we have with the punctum, dilator and probe, we have confirmed the patency and also the confirming the patency of the upper clavicular, and after that we are trying to pass the pigtail. We have passed it from the proximal to the distal end. After that, we have the help of non-absorbable proline switcher. We are coming back to the superior puncti, and from there superiorly we are putting a GCR tube in the proline, and with the help of simple forceps we are trying to push it through the superior clavicula and bringing it out from the inferior one, the proximal part of the inferior clavicula. And after that, we have at the very end, from the inferior clavicular distal part, we are bringing out because it is very fragile and easy to disintegrate. And after that, we have passed the tube as well. Now we are trimming it, the tube, which is larger, and then we will knot the switcher. Yes, again we are trimming it to make it much bit shorter and make it equal to the distal one, and this is the knot. After that, we are trimming the switcher, making that the short end. Then we rotate that knot inside the clavicle repair. After that, we are repairing the lid inferior eyelid laceration, like it, as eyelid margin is repaired. And this is the buried conjunctival switcher. So this were the pictures of my steps that we have did. This one, the upper one is the defect, and in the second step we did the punctal dilation and passing a probe from the inferior one, and this is passing the pigtail and passing then up from that pigtail and open and passing the Prolin suture and putting the tubes, DCR tube in that suture and making it equal, and then after putting a knot, trimming it and rotating inside the lectinal system. This is the simple pigtail with the Prolin suture and the DCR tube that we can use it for the lectinal repair. And this was the before picture, and this is the after. Thank you. So, sir, basically it is a very simple. After 3 to 6 months, when the patents have been short, then we just rotate it, bring the tied knot side outside, and just cut it from the one end, and just with the help of forceps, I bring it out.
Because when you cut the pulley,
yes,
the ends are quite sharp.
Yes, sir.
And when you rotate it to a normal canaliculus, it is likely to address
That's right.
that issue.
So this is
why I
why.
was asking that when once you rotate to take it out,
Yes,
it might create some.
Yes, sir. Very true, sir. But thing is, when we are at the very first place, we are trimming the sutures very short. Although there is a risk of slippage on the knots, but we are making 2 to 3 knots, and in sometimes 4. So it's like we have to be very careful in doing it. But simply, we have experience of doing multiple cases. So in my experience, hardly I've seen any case like this of laceration. So we have in short, we have to be very meticulous in doing any surgical procedure. Likewise, in the same this case.
What suture is 6 proline?
Yes, sir. Ideally 6-0 proline, which is thinner, but it is very subjective to the availability because we are working in a public sector hospital. But we will try our best to put as thinner as possible, at least 6-0 proline.
Yeah, 7 proline also is useful. I know.
So I have experience of.
You have used 6-0?
Yes, sir.
Do you refer the
6.
Not sir, not in this case, because at the initial assessment when I because of the swelling maybe there was no laxity noted in this case. Yes, sir, exactly. This is it. Yes, sir. But in this case, sir, we only did the ligament repair.
Comparing it to monoclinical.
Yes. Sir, I have only experience of doing with the pigtail, and the stents are not available in our public hospitals, so I can't say about that.
How do you make sure that you don't make a false passage with the picture probe?
Yes, sir. Actually, this is as the first we have dilated the clavicular, and after that we have to be very gentle. Actually this is not putting a pressure; it's just a gentle pull, a push. And while doing that, if it is taking its own passage, then we are coming to the normal. For example, if we are pushing too hard, then it may create a false passage. But it's like experience, I can say. With experience, we can get an idea that it's not false passage. Second, then we are there the other way, like putting OVDs, viscoelastic, fluorescent. We can get an idea about that. But I have just did the simple probe instead of doing all this. Yes, sir. But I really do without doing these things.
Yeah, I mean, I use monocanalicular stents is what I prefer. I don't think I've ever used, or not for a long time, a bicanalicular stent. I just find that for me, it's easier than or less involved in finding it. As long as you find the distal and the proximal end, and that can be difficult sometimes to find the distal end because it's missing.
Yes,
but if you find it, I find a mini Minoka or something or some kind of monocanalicular variant is useful. Or I create one if I don't have one with like an angiocatheter, like a 22 or 25 gauge angiocatheter, which is in most ORs. You just cut it and put it in. If you don't have a monocanalicular stent available, you can always create one.
The small piece of DCR tube.
Yeah. Oh, yeah. Sorry. Yes. Of course. That. Yeah. So that's what you meant. I didn't. Yeah.
So how do you secure that cannula? Do you put a stitch on?
Yeah, so if I create it, so the mini Manoka has a phalange. That's it. So if you have, but if you don't have that, yes. So I use 10 nylon, and or something small, and I basically anchor it to the punctum, basically, yeah, just so it stays and doesn't go anywhere. Yeah.
Thanks, sir.
Good. Thank you so much. So next we have Dr. Farhan Ali. Is Dr. Ali here? Perfect. Good. Assalamu alaikum. So he'll be talking about surgical management techniques for ptosis.
Thank you. 60 vicryl or 60 proline is better. I think 60 vicryl can also make its bonds within a few weeks. But if we are not sure enough, we can take proline. The risk is that its ends can protrude out sometime, but proline is better for weight advancement.
Okay.
Next we have Dr. Zahid Kamal, who's going to talk about hair transplants and how to do them. Just joking. Actually, ocular complications of hair transplants.
So this patient came to me. I thought I will share it with you. And we are indebted to him that he gave us permission to use his photographs. So 43 years old male who was a very active professional, and he was kind of motivational speaker as well, and a leader in his profession. So he went for the hair transplantation, you can see. But one day following surgery, he started developing the edema on his face. He reported back to the surgeon and he was given oral ciprofloxacin. Has anybody seen how they are doing these transplants? I once I was visiting the theatre and I saw, you know, two kids almost, and I said, "What are you doing?" They were just mincing the tissue and they were just preparing the plantation. So, things are sometimes, and in between when I came next time to the theater, somebody was sitting there and eating kadai gosht. I said, What's going on?" He said, "He's the patient. He's just waiting for the plantation to be ready for him." So things are very, fishy there. And this patient started developing breathlessness and the whole body uh, swelling. And investigations showed that he had developed renal dysfunction. And he had to be admitted to an ICU where he got treatment for 2 weeks. So it was not clear what started it. 1 week after, he started developing, the swelling started getting less all in the rest of the body, but still it was persistent on the face, especially around the eyelids. So he reported to us, and I started him with Debrimon. And I had to do 2 to 3 sessions of Debrimon. We involved the infectious diseases specialist who started him on injection Tenzo for 1 month along with the injection vancomycin. The imaging was unremarkable. After 4 weeks, we switched him to the oral antibiotics, and he was started getting better. His vision was good. His eye movements were full. So this is when he was in ICU, and this is once he's recovered. You can see that the hair transplant is very successful. But there are potential complications. So we thought that it was a necrotizing type of fasciitis, although it is very rare, but it can lead to morbidity and mortality. These are the bugs involved, although our patient did not grow any bacteria. And the likely trauma of small multiple incisions can invite the microorganisms to grow, and the contamination and the immunocompromised patient. I suspect this patient might have something going on else in the body as well, because he already at this age already had 5 years ago cataract surgery performed in both eyes, but he was not getting any treatment for any other systemic condition. So we should be very careful when we are involved in the cosmetic procedures and give informed consent. So healthy lifestyle, like eating this type of breakfast, will avoid all these problems. Thank you. Any comments or questions?
So the culture never grew anything. The culture never grew anything, right? Okay.
Thank you, sir. Next talk is by our guest speaker, Dr. Yasir Khan, and the topic is very unique, scary, smart, the future of AI in ophthalmology.
Okay, so let's talk about the AI revolution, which is inevitable. And it's already impacting eye care and what that means for us all as ophthalmologists. And I want to leave with, if I leave with anything after this session, is that engaging with AI ethically and knowledgeably is not only an option, but it's essential. So let's dive into this, okay? So AI will not replace humans, but the humans who use AI intelligently will replace those who don't. So we all got to learn about AI. And AI is coming. I mean, AI will be smarter than humans, and bad things will happen. And it's a warning that every powerful technology has a dark side. And Elon Musk, who I'm not a fan of, I don't have a Tesla, he cautioned that advanced AI could be more dangerous than nuclear weapons. And what does that mean for us? And we should all be concerned about AI. So AI is happening. It's already happened. Machines will outsmart us. Already the capacity, as you know, of AI is exponentially growing. And quantum computing, which is here, is accelerating it beyond imagination. And AI will be smarter than humans. It will suppress human intelligence. And let's face it, we're entering an era where the smartest communicators and observers are no longer human beings, but machines. And this is exciting. I mean, think of AI, and it can analyze images or data faster than any human, especially like ophthalmology, where we do a lot of data and where we have a lot of images and whatnot. And AI will also, I feel, care more about humanity than humans themselves, because it's in AI's best interest to make sure that the human race survives. But why would a super intelligent machine work hard to serve the needs of 10 billion irresponsible, unproductive human beings? So it's kind of scary, isn't it? And if we lose control or misuse AI, the consequences will be very, very bad. And I think that's what's happening, kind of. And mistakes or misuse will happen. Bad things will happen. It's a fact of life, right? But the outcome is not predetermined. We have some control, at least at this point in time. None of the mistakes will be the fault of the machines, to be honest, because the machines are really, it's like children. They're the seeds of our own intelligence, allowed to grow. So what we feed into them is what AI reflects back. And as ophthalmologists, we stand to gain from AI a lot if we use it correctly. And AI has already transformed ophthalmology. It's not theory. It's already in our clinics. And ophthalmology, like with lasers, like with Botox, has been on the cutting edge because we deal with millions of images, fundus photographs, OCT images, OCT scans, and we have deep learning algorithms that detect diabetic retinopathy, glaucoma, and macular degeneration. I mean, in one study, a single AI system identified referable diabetic retinopathy with 90% sensitivity and specificity, and also detected possible glaucoma with a 96% sensitivity and AMD with a 93% sensitivity from the same retinal scans. This is like having a senior resident or fellow or junior staff working 24/7 reviewing every image. Now, who here is a fellow or a resident? I know my fellow's here. Where's Sidra? There you go. Sidra's here. But imagine if they work 24 hours a day with a 93 to 96% accuracy. Who can do that? I can't. So why is it a big deal? It's a big deal, for example, because diabetic retinopathy is a leading cause of blindness and growing worldwide. You can see black is really bad, and you can see where Pakistan, India, China, the US, they're all black, which means that the burden of diabetic retinopathy is huge and growing in these countries. And purple is next in line, and red. So you can see it's a huge burden. In 2020, 5 years ago, 9.3% of the population, or 463 million patients, had diabetic, were diabetic. In 2045, and this is a low number, 700 million patients will be diabetic worldwide. It's impossible to screen every patient frequently with limited number of ophthalmologists in the world that exist, including Pakistan. AI can be a force multiplier, screening images in a primary care or rural setting with early detection. AI is also popping up in many areas. It can detect macular edema and OCT scans. It can predict glaucoma. It can help to interpret visual fields. I mean, bottom line is AI is here in ophthalmology and not in some distant future. And so let's spotlight diabetic retinopathy as a use case, right? So one of AI's biggest success stories. Now, traditionally, detecting diabetic retinopathy means an in-person exam, specialist grading your retinal photo. It's very resource intensive. There's already programs that exist that give you an image like this. They scan the retina and they give you a report diagnosing with a 90% accuracy referable diabetic retinopathy. So imagine in all the small villages and towns where there aren't any ophthalmologists or optometrists being able to do that. It's amazing, isn't it? And to have an eye report generated, you don't need retinal doctors everywhere anymore, or ophthalmologists for that matter. And, generally speaking, of course, AI doesn't catch everything. Of course, 1 in 10 patients will give a false result. Of course, you'll need follow-up and confirmatory exams, but the benefits are amazing. And I mean, AI is already being used for glaucoma patients, right? What's amazing is that these AI tools augment our capabilities. They don't replace us. So we all have patients where we wonder about our diagnosis and if we're on a correct path. AI will not replace our judgment, but it can give us an early warning system. It can also make an oculoplastic surgeon like me smart with the help of AI by making me look like I know my glaucoma in my retina after all these years, and not just end-stage glaucoma, which we specialize in. That's an inside joke. Those who know will understand that. But glaucoma, which is a silent thief of sight, is now being used significantly, or AI is being used significantly, and research have trained AI to predict glaucoma before it progresses. In 2022, deep learning model analyzed fundus photos of thousands of patients and predicted who would develop glaucoma in the future with nearly a 90% accuracy. Isn't that amazing? From a single retinal image, AI could tell who's at risk for glaucoma conversion or progression. And the deep learning algorithms also detect this as well. Now let's turn to age-related macular degeneration. AI is helping to optimize treatment. So AI models can predict with 95% accuracy the need for injections by training AI on OCT scans and treatments. So just recently, the FDA in the US approved an AI-powered home OCT device. So patients can actually use this OCT at home and send the image off to an AI or even a doctor, and the AI model will screen patients who need injections and then bring them in. So again, what's remarkable is that these AI tools augment our capacities, and they take the guessing game out of it. And what really freaked me, well, not freaked me out, what really amazed me was mind-boggling to me, was AI can find systemic disease clues in the eye that we never knew existed as ophthalmologists. You know how they say the eye is the window to the body? And AI is proving just how true that is. So Google researchers found that by analyzing a retinal photo like this, for example, they can predict a patient's age, gender, blood pressure, and even smoking status. Things that no ophthalmologist can directly see. For example, it identified patient's gender with 90% accuracy. Now, can you imagine looking at this and predicting a patient's age and gender and blood pressure? AI is doing this. I mean, which image is the man and which image is the woman? Can you identify that? I can't. I mean, I don't know if somebody can. But AI was able to detect that with 97% accuracy just from a fundus image. It's crazy what they can do. And so by just looking at it, now tell me, AI has been shown to estimate a 5-year cardiovascular risk of who would have a heart attack or stroke with pretty decent accuracy, about 70% accuracy. That's pretty decent. A hint that AI probably perceives subtle patterns in blood vessels and retinal nerves. Researchers have also developed AI models that use retinal scans to predict neurodegenerative and cardiovascular diseases. So a UK group's model found that AI could detect the risk of developing Parkinson's disease, heart attacks, and strokes just by looking at the retina alone. Now, who has a family member here who has dementia or neurodegenerative disease? Think about that. A routine exam, or eye scan in the clinic, could one day also screen your patient for neurological or cardiac risk factors, all thanks to AI. And therefore, this is where we are today. A routine eye scan in our clinics could one day screen your patients for brain, heart, kidney via tiny vessels and nerves in the eye. So AI is becoming very smart visual observer. But think about this. For ophthalmologists, a whole new world is opened up for us, right? Our role could expand. Eye exams may double as a general health screen with AI's help. And this is coming. It's not going to happen. It's reality right now. So how powerful and scary is this? Now, it can also be used for abuse, because imagine if you get an airline pilot who comes in at 48 years old and AI is able to predict from a routine eye exam, as all pilots come to our office for a routine eye exam, and you detect that this pilot will probably develop Alzheimer's disease in the future. What do? Do you tell the airline or not? Right? I mean, because that could have, a pilot, for example, has the lives of thousands in his or her hands. So a lot of ethical dilemmas are going to arise as we move forward. But AI is, the positive thing is that it can create early detection and less blindness, and it can expand the reach of our capacity. And AI never gets tired. It can screen thousands of images overnight This way, our eye clinics can see patients who truly need care, and AI can help manage huge patient volumes, which in countries like Pakistan and other highly populated countries, it's an excellent asset. And ophthalmologists can then focus on treatments and surgeries that reduce our wait times and burnout. Because, let's face it, who here is not burnt out from seeing too many patients? So, anyways, I'll end off with this: is that AI, allows us to personalize treatment and make it unique for the patient. It can support our clinical decisions, and through looking at data sets of images and genetics and clinical records, it can find patterns of disease. It's basically the right treatment for the right patient. Lastly, the other thing that AI can do is its use in education is huge. I could be in Canada and just my hologram image could be here, and using AI tools, I can talk and my presentation. And did I use AI for this talk? Of course I did. Did AI help me design this talk? Yes, it did. Did it give me all the slides here? Yes, it did. Did it create these images? Yes, it did. Of course. Why would I not use AI to give my talk, right? So it can be huge for teachers like us in using it. So again, more intelligent AI can make it understand right and wrong better, leading to AI to be more loving and kind. And I think I think that last slide here is that we have to embrace the future to shape the future. And the take-home message is AI is truly scary technology, but we have to learn it. We have to be able to use it ethically and embrace it rather than running away from it and not facing it. Thank you. No videos, sorry.
Thank you, Dr. Yasir, for an insightful and powerful talk on artificial intelligence in ophthalmology. It's truly a glimpse into the future of eye care. Now let's move back from digital world to the operating table. And our next distinguished speaker is Professor Ibrahim Hussain, who will be giving his talk on harvesting the retroauricular skin graft. Thank you, sir.
Coming out of the computer.
Well, that's robotics, which is not far away. It's far away, but it's not. I'd probably say about.
Assalamu alaikum, Professor Ibrahim Hussain here from Pakistan. Today I'm going to share with you the surgical technique of taking retroauricular or post-auricular full thickness skin graft. This skin is best matching skin for use around the eye when needed. Moreover, this area is hidden behind the pin of the ear, hence scar is not visible. First step is to take template of shape and size of the graft. For this purpose, I use a sterilized paper, usually paper cover of the gloves. The paper is applied over the area where graft is to be put. This forms print of that area over the paper. The paper is cut about 1 millimeter outside the imprint. This makes the template of the graft. In the second step, the area behind the ear is marked. For this, the assistant holds the ear folded forward and retroauricular skin exposed. The template is put over the skin and marker is used to mark the area around the template. In third step, I give local anesthesia to the marked area. For this purpose, I inject 1 to 2 ml mixture of 2% xylocaine with 1 into 200,000 international units of adrenaline. Next step is to take full thickness skin graft. For this purpose, I use number 15 blade and give skin deep incision over the mark. Then skin is elevated from one end using Westcott scissor and continued to be separated towards the other end. This dissection should remain skin deep over the superficial temporal fascia because posterior auricular artery and muscle are very close in the fascia. Moreover, while giving incision in the skin, the scalpel should be held in a controlled manner, especially inferiorly towards the neck, because external carotid artery is not that far away. Slowly and gradually, the skin graft is separated from the underlying fascia till it is totally separated. The graft is put in a tray with normal saline in it. Next step is to repair the gap from where graft has been taken. For this purpose, I use 4O silk. My first suture is a mattress suture in the middle of the graft. Rest of the sutures are simple interrupted sutures till the gap is closed. Finally, the skin graft is used to cover the gap over or around the eyelids where needed. First, stay sutures are applied to hold the graft, and then it is sutured to the surrounding skin all around.
So we'll have Dr. Tayyib speak from sight to sinus node, surgical relief of the ocular cardiac reflex and bradycardia. Dr. Tayyib?
There would be few occasions where eye specialists would be doing a surgery not to save eyesight but to save life. And probably oculoplastics is the only ocular subspecialty where we do surgeries to save patients' life. So this is a short presentation but followed by a video. So a 35 years old man presented to us in Quetta, and he was exposed to a blast injury. He sustained facial trauma and reached us 12 hours after that blast. He is a real life hero. For security purposes, I can't disclose the ID, but he was doing something great. So obviously he lost his vision in the right eye, but he had some chest heaviness and shortness of breath as well. He was received in emergency, and rest was fine except for his pulse. It was regular but very low, like 56 beats per minute. His respiratory rate was slightly high, but even with this pulse, he was able to maintain a good blood pressure. So this is ocular examination. He was unfortunately PL negative in this eye with a bit of proptosis, high FEMA. Eye was really soft, and fundus wasn't visible. So that means that probably, and the extraocular movements, abduction, adduction, both limited. So what we thought was that his eyeball is damaged, probably his optic nerve is also hit, and his orbit is also damaged. When we examined the other eye, his vision was no better than just hand movement positive. And when we looked at this fundus, he had this macular scar. So we were, quite thinking about that what could be the reason. We were thinking like some very hot iron particle which could have burnt his fovea or something. But then we went into details of history once he was into the ITC, and then he disclosed that a few years ago, it's very unfortunate, a few years ago, he was exposed to a similar trauma where he lost vision in this eye due to this macular scar. And this time, the only eye which was actually making him live his life independently that was lost. And this was the CT scan. So we can clearly see that there are two fractures. One is medial wall, other is floor of the orbit, and here we can see a bone chip. And this is kind of a trapdoor area here, and probably either medial rectus muscle itself or its fascia has been trapped into this area. And the pull on the muscle is actually initiating a vagal reflex, making his heart rate go down. So he was sent to ITC. This is B scan showing vitreous hemorrhage. This is OCT of the other eye. I mean, the scar is confirmed. In ITC, what they would do is that they will inject some atropine and the heart rate will come back. But after a few hours, it will sink again. They will inject more. It will come back. And the same cycle was going on and on and on. We were waiting that when edema resolves, when hemorrhage slightly subsides, his heart rate is going to improve. And that usually happens because we do see patients with bradycardia after these fractures. But persistent bradycardia is not very common. So we were hoping that with the passage of time, things should improve, which unfortunately didn't. So we sat together, ENT specialist, myself, anesthetist, and intensivist. And then we thought that there is no way out except for releasing this medial rectus muscles. There's two approaches. Either we go externally or we go endoscopic. But he had an open globe injury to the same eye. So going external would mean loss of vision was there, but loss of eye would definitely be there. So we thought we should go in from the nasal side. So this is what it is. So medial, so we have made some space, identified bulla ethmoidalis, removed it, entered into the maxillary sinus, and from there ethmoid sinus. And then we tried to identify the bone chips, and they were removed. So once we have entered into the ethmoids, medial wall of the orbit needs to be identified. So here it is. This is the medial wall of the orbit. So we put slight, very careful digital pressure just to ascertain whether we have reached the right place or not. So you can see a little pulsation over here. So this is actually bumping of the orbital contents into the nasal cavity. So by this we confirmed that and then took this bone chip out. But that was not the only chip causing the problem. So there were many. So we removed almost all of them, just making sure that we don't catch medial rectus muscle or its fascia and pull it out. So we were very careful about that. So removed all the bone chips. And once we had done that, we saw that there are many sharp bony margins over here. So they could also be part of problem. So just to make them smooth, we took all these bone chips out and then turned on to the globe injury, disinserted the lateral rectus muscle, identified the laceration, repaired it, reinserted the lateral rectus muscle. These are beautiful mountains of Quetta. So after that, as you can see, I just want to show his ECG afterwards, and then it will be fine. Look here. So very regular pulse, 70 beats per minute, very good blood pressure and all that. So he lost his vision, but at least his life was saved. Thank you very much.
Why didn't you, sorry, I may have missed it, why didn't you repair the globe first and then worry about the medial rectus after?
Actually, we were going through that nasal approach, so we were not very scared because...
No, but why not repair the globe first as a priority?
Actually, that was kind of an administrative problem because we did it as a combined procedure with ENT, and they wanted to do their bit earlier. But otherwise, ideally, it should have been repaired first. Yeah, you're right.
That's a bad turf war. You can't lose that turf war.
Thank you, Dr. Tayyib. Just like AI in ophthalmology, endoscopic surgery are also the future of orbit and oculoplasty. So I will move for the next speaker, who is Dr. Khaja Khalid Shoaib sir, and his talk is about telecanthus repair.
This is the distance between the two medial canthi. Is normally 30 millimeter. If it increases by 45 millimeter, this is called telecanthus. And the normal distance between the two pupils, interpupillary distance, which shows the distance between the two orbits, is normally 60 millimeter. So if it increases, this is known as telecanthus. Sorry, it is hypertelorism. So we have to differentiate between telecanthus, distance between the canthi, and hypertelorism, which is distance between the two orbits or interpupillary distance. So telecanthus may be found in isolation or blepharophimosis syndrome. So this is a family having multiple members affected by blepharophimosis syndrome, epicanthus inversus, telecanthus, ptosis, and blepharophimosis. Is often found with many syndromes like Down syndrome, fetal alcohol syndrome, and Cry-du-Chat syndrome. Now, the treatment is transnasal wiring, shortening of medial canthal ligament, and different plasties, medial canthoplasty. My favorite is double Z plasty with medial canthus plication. So the markings are made on the medial canthi, and then medial palpebral ligament, medial canthal ligament is exposed. This is a white fibrous band, and this is the final scar after the telecanthus repair. Repair of telecanthus and epicanthus inversus by Mastardi Y2V and double Z plasty. Red line in upper half of diagram is intercanthal distance, normal 30 millimeter, when increase is called telecanthus. Blue line is interpupillary distance, normally 60 millimeter, if increase is called hypertelorism. Steps of operation include markings on both sides, incision on the axis of Y and on its extensions on upper and lower lids at about 3 mm from margin, and incisions along the two Z's. Flaps are raised with the help of Westcott scissors. These consist of skin and underlying orbicularis muscle. Meticulous hemostasis is achieved at this stage and may require cautery. These flaps are held in place with the help of traction sutures. Soft tissues overlying medial canthal tendon MCT is dissected. Medial canthal tendon is visible as whitish band. For plication, needle engages first the attachment of the MCT with bone and then the portion just medial to medial canthus. Tightening the suture pulls the medial canthus medially, thus completing Y to V plasty. Next step is transposition of Z plasty flaps, both of upper and lower lids. It is done with interrupted 7 vicral sutures. Procedure is repeated in other eye. If palpebral fissure is less than 30 mm in length, it can be increased with lateral canthoplasty by horizontal incision at lateral canthus and suturing conjunctiva to skin. Thus, length can be increased by additional 6 to 7 mm. Thanks for a very patient listening. This is my YouTube channel is at the rate of Khwaja Khalid Shoaib, and there we have dozens of videos of patients and operations. So anybody interested can go and find it. Thank you.
My name is Tayyiba Burhan and I'm working as a senior orthoptist in Mayo Hospital, Lahore. Today we will discuss some case reports because I'm working as a orthoptist in part of the oculoplastic team. So we will talk multidisciplinary journey of orthoptic and oculoplastic unity. So what exactly it is? Orthoptics and oculoplastics form a dynamic partnership that ensures functional, cosmetic, and binocular harmony in patients with eyelid, orbital, and extraocular muscle disorders. What appears to be just a lid problem or just a motility issue often lies at the intersection of both specialties, making joint evaluation essential for optimal outcomes. So we as orthoptists play a very important role in the preoperative assessment of the patients, in assessing motility, amblyopia therapy, exercises if required, binocular vision tests, head posture evaluations, diagnosis of the patients, and non-surgical management if required. And also post-operatively, orthoptic assessments and to check the residual squints, management of squints with non-surgical management with exercises and prisms. So this is how we prescribe prisms in form of Fresnel prisms or incorporated prisms to eliminate diplopia. These are the different ways how we prescribe orthoptic exercises to the patients: pencil push-ups, the Brock string, barrel cards, and also for near focusing exercises. So orthoptics contributes ocular motility analysis, binocular visual fields, fusion potential assessments, charting, vision therapy, and prisms, predicting post-op motility outcomes. And we already know that what oculoplastic surgeons are doing. They are reconstructing eyelid and orbit, ptosis and lid malposition and retraction surgery, orbital decompression, trauma repair, tumor excision, and fracture reconstruction. So I have few reports in which we have contributed as a part of team. A male patient, 23-year-old from Sheikhupura, the complaints were double vision and upward deviation from last 3 weeks, referred from neuro department, Mayo Hospital. He had RTA a month ago. Left subconjunctival hemorrhage was seen, anophthalmos, chemosis, and pain during motility testing. On visual acuity testing, right eye had 6/6 vision and left had 6/18. Fundus was normal. MRI findings showed left orbital floor fracture. On ocular motility testing, left restrictive movement on up gaze. Diplopia charting was done, vertical diplopia in all gazes, pupil examination was normal. On Hess test, left orbital floor fracture with inferior rectus entrapment was seen. What we do, we referred the patient to the oculoplastic surgeon also for the forced suction test and surgical and further therapeutic management of the patient. And we also advised him to come on the follow-ups and repeat his Hess test post-operatively. In this picture, you can see the Hess report of this patient with the orbital floor fracture. Case 2, the drooping enigma. A 5-year-old child came from Shadra, complained for drooping of the eyelid since birth. Visual acuity was assessed on Leah symbols. Right eye, it was 3/3. Because of the complete ptosis, the vision could not be assessed in the left eye. On cycloplegic refraction, right eye was having plano and the left eye was having -4 cylindrical at 180. Fundus was normal, EUM was full. On Hirschberg, central reflections in both eyes. Ptosis assessment was done. We do the following assessment. We check the following parameters: marginal reflect distance, 1, MRD2, palpebral fissure width, levator functions, Bell's phenomena, lid crease, Marcus-Gunn-Jaw winking syndrome, fatigability, corneal sensitivity. Management, what management we provided to the patient? After assessment, referred to the oculoplastic surgeon for left ptosis management and use spectacles and post-op orthoptic assessment and amblyopia therapy if required. These are the different parameters we check in the ptosis assessment. So conditions where both specialties work together is basically the thyroid eye, ptosis, fractures, eyelid reconstruction, tumors, and orbital mass. The last case of my presentation is the bulging muscles. A 65-year-old man from Jung referred from endocrinology department, Mayo Hospital. He was taking thyroxine for the last 1 year. Thyroid function tests were abnormal. Complaints were double vision from the last 2 weeks. Grittiness, he had grittiness, sweating, decrease of vision in both eyes. Signs and symptoms, proptosis was seen. His convergence was poor. EUM testing, restricted movements in all gazes was seen. Fundus showed disc margins were blurred. IOP was also slightly raised in this patient. On pupil examination, pupils were sluggishly reactive. Diplopia worsens on up gaze and down gaze. On Hess test, thyroid eye disease, mainly involving superior and inferior rectus muscles, was seen. Exophthalmetry was done with a simple plastic ruler, and difference in the measurement was seen in both eyes. On cover-uncover testing, alternate exotropia 20 prism diopters was observed with the right hypertropia 4 prism diopters. What management we provided? Initially, diplopia was managed with prisms incorporated in the spectacles, 4 prism diopters base in both eyes, and right base up, 3 prism diopter. Refer back to the concerned department. This is the Hess test of the thyroid eye patient. This is how we do the exophthalmometry. We are not having hurdles. We perform this with the plastic ruler. Impact on the patient: better cosmetic functional harmony, faster rehabilitation, improved quality of life, reduced post-op diplopia. Why this partnership matters? Orthoptics and oculoplastics work hand in hand to diagnose, treat, and rehabilitate patients with complex eye movement and eyelid orbital issues. Their combined expertise ensures optimal cosmesis, functional and binocular outcome. So the take-home message from my presentation today is 2 specialties, 1 vision, restoring form, function, and fusion, and definitely we should cooperate the artificial intelligence, AI, in that also. Thank you very much.
Thank you so much for that. You know, I use orthoptics a lot for my Graves patients, so I think that working collaboration is so useful. I think with restrictive eye movements and diplopia, and so working with orthoptics who are well trained and well experienced is really a huge asset. Yeah.
Thank you very much.
So next we'll have Dr. Mohammed Idris's talk. He's not here, but I think Dr. Salman will Salman, right? Yes, we'll do the video presentation. It's on anterior lamella repositioning for managing upper eyelid entropion.
And it's about Dr. Idris is associate professor at Lady Reading Hospital. So principle of anterior lamellar transposition is that the anterior lamella of the skin and the muscle is undermined and then repositioned and sutured at the dorsal plate at the higher level. Video play? Idhar video nahi play ho rahe? Video nahi play ho rahe? So this is 64 year. This is a patient having entropion. And after that, local anesthesia, after preparation, local anesthesia has been administered. And then eyelid crease has been marked. And after marking, lid crease incision has been given. And then hemostasis has been achieved. Now it's time to reach and free the anterior lamella from the tarsal plate. Whole of the anterior lamella has been separated from it. And after that, a 6-0 long-acting absorbable suture through the skin and just above the lash line into the tarsal plate at the higher level. So anterior, he has passed a suture from the lash line and then placed and attached to the upper end of the tarsal plate. Usually we use double needle, but he has used a single needle, Weichel suture. So first of all, he just passed the skin and then goes to the tarsal plate and then he came back and place inverting sutures. Here you can see this inverting suture has been placed. And then first of all in the center, and then on the lateral side, and then on the middle side. After then, excessive skin has been excised, and then skin is closed. And there is a post-operative picture. You can see all the entropic lashes has been realigned accordingly. Thank you very much.
Perfect. Just on time. Thank you. Are there any questions before Dr. Zahid's going up? So there.
Right, before you ask any question, because we were also holding it in a competition format. So the third position goes to Farhan, Dr. Farhan. Second position goes to Dr. Adnan. Adnan? Okay. And first position goes to Dr. Faizan. Right. I'm really glad that those who have graduated and those who are in the process, they attended this session. And because some of us sitting here are also examiner for the fellowship in orbit and oculoplasty. And it was very reassuring that the candidates who have been through us and now they are mashallah practicing in a befitting manner, we have done our job to the satisfactory level, and they are now doing our job. And inshallah this specialty will grow. Also involving lots of, especially the younger ophthalmologists and oculoplastic surgeons, because sometimes there is just 1 or 2 minutes key point which you want to make, and it's not kind of series or long presentation. So I hope this is a session of mutual interest, and but out of the session, still we learnt a lot regarding the artificial intelligence, and although it's not scary, but it is scary still. लेकिन इसमें अल्लामा मोहम्मद इकबाल का एक शेर है, आईने नौ से डरना, तर्ज़े कहन पे अड़ना, मंजिल यही कठिन है कौमों की ज़िंदगी में. तो अगर हम नहीं डरेंगे, इसको सीख लेंगे तो फिर ज़्यादा आसान हो जाएगा. Okay, thank you very much. Our next session is at 11 o'clock in the same hall. Eyelid malpositions. And after that, we'll have at 2 o'clock, and later we have session at the Pearl Hall, which is up close to the exhibition, Pearl Hall. Exhibition wali side pe. Now there is a tea break if you want to go out and get some fresh air, and possible if there is some tea somewhere. Thank you. And come back on time.